And good evening, everyone. So, welcome. So, today we're going to cover neurodevelopmental disorders in children and adolescents. And so, what I want to do is walk you through this, but in a different manner. I want you to take the lens of how this child's nervous system is interacting with their environment and their family and the demands placed upon them. So, as future psych NPs, you're going to have to meet kids whose struggles don't fit very neatly into different categories. And you're also going to encounter families who are trying their best but are overwhelmed. So, I make that distinction because when you deal with children, we don't call them the patient, we call them the identified patient. And the reason for that is somehow the system they exist in has agreed that this is going to be the sick person representative of the family unit. So they're called the identified patient because you're holding out hope that this person may actually just be having a normal reaction to a chaotic home environment. So we don't want to pathologize their normal coping strategies. The goal today is to give you this framework that you can actually use in practice. And these frameworks are going to help you avoid overdiagnosis and hopefully underdiagnosis. And I want you to remain grounded in what functions are being done or not done rather than the label you apply. So, we're going to talk about autism spectrum disorder, Rett syndrome, intellectual disability, some specific learning disorders, and then we'll finish with ADHD. And we're also going to step back and I'm going to address this issue of is this a disorder or natural variation? Because that's all the rage now, right? We get the phrase neuroatypical or neurodivergent as if we're trying to describe something like handedness. So we'll talk about that as well. And if this is a disorder, what systemic factors are perpetuating this thing? What's keeping this child stuck? So you're going to notice several themes. The first is this notion of diagnostic rigor. Your job is not to just name symptoms, it's to understand why the symptoms are happening. Second, I want you to reframe your perspective. This reframing perspective looks at neurodiversity not as an ideology, but more as a reminder that the nervous system comes in many different configurations. And our role is going to be to understand whether a configuration is causing the impairment or distress or disability. And then finally, I want to take this family systems approach. A child is never walking into your office alone, right? They're always coming with the family system attached to them, the environment they're growing up in. And then finally, we'll talk about ADHD as a diagnosis of exclusion, but we want to use this capacity, demand, and resilience model to set some functional goals that can actually improve outcomes. So by the end of today, you're going to have a clear, structured way to evaluate the developmental concerns and help you make sound differential diagnosis to help families move from their chaos to clarity and hopefully to avoid misdiagnosis. So let's get started. Okay, here we go. So, why does this matter? So, before we dive into any one specific disorder, I want to ground you in why early identification actually matters. Neurodevelopment is not a straight line from point A to point B. It's a series of branching paths. So the earlier you can intervene, the more you can influence the branches while the brain is still highly plastic. That concept of neuroplasticity is alive and well, especially in periods of rapid growth and development. So, what this means is if you intervene properly, that leads to better language outcomes, better social functioning, fewer secondary complications like anxiety or eventually school refusal. But the opposite is also true. You will find some diagnosis shopping at certain times of the year. And so, sorry, I was checking the chat. So, what's going to happen is misdiagnosis can send a child down the wrong path. And if we label a child as autistic when what's really happening is untreated anxiety, or if you call the inattention ADHD, but really it's a trauma response or a sleep disorder, the interventions are going to miss the mark and may even make the situation worse. And when the interventions miss the mark, then the families are going to internalize the wrong story about who their child is. That creates a preventable strain and stigma and frustration with everybody involved. So take a look at this slide here with respect to the prevalence numbers. So autism is estimated at around 1 in 59 as a result of the new definition and new screening methods. But what that tells you is this also tends to vary by region and by diagnostic practices. ADHD sits at around 5% of the child population. It is more prevalent and common in the United States than Europe, which brings a critique to the field. And also, more than half of the people with ADHD as children continue into adulthood. So what that means is not 100% do. Learning disorders, dyslexia, dyscalculia, dysgraphia, these go somewhere between 5 and 15% of school-age children, and they're frequently missed because the child will present with behavioral problems that the teacher's not expecting the learning disorder, right? So you'll see the behavior as a result of frustration with the class material or boredom or checking out, and so it comes out in behavior problems. The other thing is intellectual disabilities, about 1 to 3% globally. And part of our role is going to be to distinguish something like intellectual disability from a learning disorder or a language difference. Now, you don't do this in a vacuum, and this is not something you do in a single visit. What you're going to do in your visit is rule out the things that you can definitely address, but it's not uncommon in children to refer for neuropsych testing for diagnostic clarity because they can specialize on age-appropriate psychometrically valid tests. The main takeaway from all this is that these conditions are fairly common, they're highly impactful, and also a lot of them will overlap. And none of these occur in a vacuum. So that's where that family system lens needs to play in. A neurodevelopmental disorder changes the dynamics across the entire family. So siblings, parents, school relationships, even extended family are going to be affected by a neurodevelopmental disorder diagnosis. So when you evaluate a child, you are evaluating the whole system that's adopting and taking care of this child. And that, keep in mind, as they develop new skills, as they progress, those needs and demands are going to change as well. So it's not even like you're dealing in a steady state. You're dealing in a continually changing environment. So it's important that you understand that system level impact so that you can build a realistic care plan. So as we move forward, keep these two guiding principles in mind. Early identification does alter the developmental trajectory, and every neurodevelopmental concern is going to have a ripple effect beyond the individual child. One of the most important skills you'll develop as a Psych NP is this being able to hold two perspectives at the same time. So we have the traditional medical model, and then we have the neurodiversity informed variation model. Both of these have strengths, but both can also be misused. Your job here is not to pick a side. It's to understand which lens is going to help you make the best clinical decision for the child that's in front of you now. So we'll start with the medical model. So this medical model tends to focus on impairment and distress. Under this lens, the diagnosis is the label tool. The label tool. What that means is when you apply that label, you're doing it as a tool because that is often the ticket that allows families to access needed services and therapies and school accommodations. That's the reason for the label. The medical model reminds you that an untreated developmental challenge can accumulate a lot of risk over time for anxiety, depression, school failure, family conflict, and these are not trivial. So the variation model, on the other hand, this is from neurodiversity social movement, essentially. This treats differences in wiring, like, say, autism or ADHD, as traits, the way we treat things like left-handedness. Now, statistically, it's less common, but not inherently pathological. From this perspective, the problem isn't the child, it's the mismatch between their nervous system and the environment around them. So the emphasis from this perspective is going to be on strengths and adaptation and modifying expectations instead of forcing conformity. That only works at certain levels. On some level, the world is not going to conform to you. The person is going to need to learn to build capacity in order to live in the world. But it needs to be age appropriate. So both of these are clinically useful, but if you only use the medical model, you're going to risk pathologizing normal variations. And if you only use the variation model, you're going to miss real impairment and delay intervention. So most children will benefit if you integrate the two. So you need to recognize their strengths and individuality while still intervening when the symptoms cause a functional impairment. Pay attention to functional impairment, not just the label, because it all comes in a matter of degrees. Now, when we talk about neurodevelopmental disorders, it's easy to get stuck in the behavioral descriptions. So what the child does or doesn't do. So research continues to reinforce something that's really critical, and that is that these are not simply behavior patterns. These things are reflecting distinct neurotypes with identifiable, though not diagnostic, biological signatures. So let's start first with brain connectivity. So there are large-scale imaging analysis that show consistent patterns of autistic individuals tend to have weaker connectivity in certain attention and social networks. But while these individuals with ADHD, they often show a hyperconnectivity in the same regions. So even though the behaviors may look similar, difficulty sustaining attention or social challenges, the underlying wiring is different. So this helps us in our understanding of dimensional thinking, that is to say, replacing that old categorical approach, basically that checkbox psychiatry. Also, genetically, studies have shown that there are 4 or more subtype clusters along autism spectrum disorder and ADHD, and they're each associated with different traits and severity profiles. But the key point is that genetics increases risk. It doesn't determine the destiny. So these clusters are helpful for understanding heterogeneity, but they don't map cleanly onto DSM categories, and they do not diagnose anything by themselves. So there's no blood test or brain scan to say, aha, you have this situation. All of this is really intended for research purposes. And there are correlational findings like handedness and hypermobility in people with neurodivergent traits, things like autism spectrum, ADHD, and learning disorders. So showing left-handedness to 2 or 3 times more often than, say, the general population in people with these conditions. So it's an interesting marker of early brain lateralization, but again, this is not something you're going to diagnose. It's like something I know, that's an interesting finding. And the other thing to pay attention to is this issue of hypermobility. That's often associated with connective tissue conditions like Ehlers-Danlos syndrome. And that's often associated, and that's often pretty notable, but not causal, just overlap. And similarly, there's overlap with ADHD and autistic traits. So it's a reminder that the body is not compartmentalizing, connective tissue, autonomic regulation, neurodevelopment, all of that intersects. So let me just make this point especially clear here, and I'll do this again when you come to psychopharm. Correlation is not causation. Repeat that to yourself 3 times. Correlation is not causation. These are biological findings that help you validate the patient's experience and understand their symptoms and to develop patterns, but these should never, ever be used to pathologize normal traits or to gatekeep a diagnosis. It's bad science if you equate the two. Okay, so every neurodevelopmental evaluation has to start here. Family systems. So before we talk about these symptoms or checklists, we're going to start with the system that the child lives in. The system is the biopsychosocial and cultural model that I've talked to you about at every lecture since the first day. This shapes both the child's behavior and the meaning we assign to it. So at the biological level, you're assessing things like genetic loading, like what runs in the family. Are there autism traits, ADHD, learning differences, anxiety? These clusters rarely occur independently. So you're also going to watch for medical comorbidities that often travel with these neurodevelopmental profiles, things like seizures, GI issues, sleep disturbances, sensory modulation differences. The biology doesn't excuse the behavior, but it absolutely informs how the brain is functioning from day to day. So psychologically, what you're looking for is regulation. How does the child handle frustration? How easily do they shift tasks? What do their executive functioning skills look like? Planning, inhibition, cognitive flexibility. These are all foundational to behavior. So the child who won't do something is very often a child who simply can't do it yet. So part of the treatment is to provide age-appropriate anticipatory guidance. Social and systemic factors are where many cases seem to get stuck. So a child's functioning is deeply shaped by their environment. Is the classroom too loud? Is the teaching style too fast-paced? Not here. Are peers accepting the child? Is the family unintentionally enabling avoidance patterns? Or are they providing these developmentally appropriate accommodations? The other thing is cultural norms, which tend to determine what is seen as an impairment versus a simple difference. So, what one culture labels as hyperactive, another might celebrate as energetic and socially dominant. And at the center of all this is this child. Who are they developmentally? What's their temperament like? How are they neurologically? You can't understand a child's symptoms without understanding their context. And when you intervene, you're intervening not only in the child's life, but in the biology, the psychology, and the social systems that they're living in. So as we move forward now into the specific disorders, keep this biopsychosocial cultural lens in mind and don't reduce children to symptoms. Expand your view to the systems that are shaping the symptoms. They may be developing for a reason. Well, they are developing for a reason, but your job is to find out what. So this is one of the most important frameworks that you're going to use in child mental health. Almost every neurodevelopmental presentation, whether it's autism, ADHD, learning differences, anxiety, or behavior struggles, can be understood through the relationship between capacity, demands, and resilience. So look at the left side first. That's the white knuckling state. And this is considered low capacity paired with high demands. And capacity refers to the child's actual skills, their executive function, their regulation, their language, their sensory tolerance, their cognitive flexibility. Now, when those capacity features are limited and the world keeps demanding more and more, the child is going to use enormous amounts of energy just to survive the day. That orange bar represents the masking and burnout that the child is doing in the role to be at the just okay level. But the cost is catastrophic to them internally because when the child lives with white knuckling mode, they come home like exhausted, depleted, they melt down, they withdraw, or they shut down. So that's not defiance, that's neurological exhaustion. And the more effort they spend compensating, then the less energy that remains for learning, socializing, and emotional regulation. So this is where we see escalation of behavior and regression start to develop. And what looks like a behavior problem can often be just a mismatch problem. Now take a look here at the right side of the screen there. This is the thriving state. Now here we're adjusting the environment so the demands match the child's true developmental capacity. That might mean things like reducing sensory overload, changing expectations, providing scaffolding for the tasks. But at the same time, we have to build skills gradually. So we want to work on emotional regulation and planning and flexibility and distress and frustration tolerance. Because when that capacity rises and demands are right sized, the child no longer then has to white knuckle themselves through the day. Their resilience becomes healthy and sustainable and hopefully less necessary because the capacity has expanded. This framework gives you an immediate clinical path. So if your child that you're seeing is struggling, you can intervene either by adjusting the demands or building capacity. And it's not one or the other, it's both and. So most children need both. And your goal over time is to provide this care to help the child move from burnout trajectory into something where they can thrive. And you're doing this always with the primary caregivers, parents and the like, coming along. Keep this model in mind now as you move through the rest of this lecture, because this is going to help you differentiate things like ADHD from anxiety, from sensory overload, from oppositional behavior, and maybe underdeveloped skills from misbehavior. So one of the most powerful interventions you can offer a family is helping them distinguish accommodation from enabling. And I do this all the way to my failure to launch kids in their 30s. Accommodation versus enabling. So get really good at distinguishing this. Many of the behaviors families bring to you, rigidity, meltdowns, avoidance, are actually shaped by well-intentioned patterns at home. The problem is parents are doing the best they can, but the strategies they use are often undermining what they want the outcome to be. So parents, they try to determine whether a child is able to build capacity or becomes more dependent. On the left side here, you'll see accommodation is about capacity building, or at least it should be, because this is where we remove unnecessary barriers so the child can actually demonstrate their skills. A quiet testing room, visual checklist, breaking tasks into steps. These aren't crutches, they're scaffolds. So scaffolding is temporary by design. As the child's skills strengthen, the scaffold should fade. And then what happens is their world becomes larger and their autonomy increases. On the right here, you see enabling, and this usually comes from a place of love and or exhaustion, frankly. So enabling, what this does is it removes the challenge altogether. It reduces distress in the moment, and then usually the parent's distress as well. But at the cost of what? It's easy now, but it's at the cost of the child's long-term growth and their ability to build capacity. So if a parent dresses a capable child every morning, or makes their breakfast, or packs their lunch, or reminds of the homework, because it's faster and it avoids conflicts, that child loses the opportunity to build competence and confidence. And the enabling shrinks the child's world into a state of perpetual dependence. So the litmus test at the bottom here is kind of useful. So what you got to do is you need to ask, does this change, improve function without shrinking the child's world? If the answer is yes, that's accommodation. If the intervention makes life easier but reduces participation, exposure, independence, then we would call that enabling. And the nuance in this is that sometimes what looks like enabling is actually a necessary survival strategy when the child is in white knuckling state. But if capacity hasn't been built yet, some temporary enabling may prevent complete burnout. But we always want to pair that with a long-term plan. So the goal is always to expand capacity and to gradually re-expose the child to developmentally appropriate demands. Your job is to help families identify where is that line and to shift their patterns just enough to support growth that's developmentally appropriate without overwhelming the child. Now, when you perform a mental status exam on a child, you're not doing a shortened adult exam. What you're doing is a developmentally attuned exam. And this means everything from your language to your expectations needs to match the child's developmental stage, not their age in years, because they may not match. So let's start with adapting the stage. So imagine here we have like a 10-year-old with intellectual disability, and they may function like a preschooler in some domains. A teenager with autism may have advanced vocabulary, but very limited social reasoning. Your job is going to be to tune your communication to their developmental bandwidth so that you don't overestimate or underestimate their skills. The other thing you're going to have to do while doing this, that therapeutic alliance applies here, but it needs to be both with kid and parents. You're going to have to foster trust with the children. And it's triadic rather than dyadic here. You, the child, and the caregiver all need to be aligned, because if one of you is not aligned, they're going to start sabotaging. So kids will watch their parents' body language to decide whether you are safe. And if the parent is anxious or guarded or adversarial, the child is going to mirror that. So your first task is going to be often attuning to the caregiver and creating that sense of calm collaboration. Once the adult trusts you, the child will usually follow. The other thing to pay attention to is a lot of this needs to be as passively observed as possible, because you may interfere and change the dynamic. So this is going to be one of your most powerful tools. Kids do tell the truth with behavior more so than with words. So watch how they separate from the caregiver, how they handle transitions, how they wait, how they respond when frustrated. These are the moments that are going to give you more diagnostic data than any direct question. Then we also have the play environment. So play is said to be the native language of childhood. And when you use toys and drawings and games and even simple tasks like building blocks, you can assess affect, motor coordination, problem solving, social reciprocity, frustration tolerance, without the child ever feeling examined. So for many neurodivergent children, play reveals the skills that structured questioning may not be able to get at. Finally, we need to contend with the issue of safety and sensitive topics. Once a child reaches adolescence, you must routinely assess for substance use disorder, sexual and activity, exploitation, safety, and suicidality. For these topics, parents usually need to step out. But you do this by building a bond and assuring the parents that you're going to tell them if anything dangerous comes up. But you need to build this trust and alliance with the kid. There is a mnemonic screening tool. It's called HEADS, or HEADS rather, home, education, activity, drugs, sexuality, and suicide. And you can use that as a mnemonic to remember. If you work in child adolescent, that will become second nature to you. If not, you can write it down and refer to it as needed. But remember, you need to make sure you're communicating privacy, because that will build honesty, and then honesty is going to be useful to getting insight and finding out what's going on. And you also want to disclaim to the kids up front, there are some things you have to report for their own safety. Say that up front, and then let them tell you. But you realize you're all mandated reporters as well. So keep that in mind. So the idea here is that the mental status exam is not an interrogation, right? It's supposed to be relationally developmental, observational, and it needs to adapt to the child's world rather than forcing that child to adapt to ours. Now, before we go any further, I need to acknowledge something about developmental milestones and the charts. They're incredibly detailed, but you're not expected to memorize them as a psychiatric nurse practitioner, okay? Your job is it's not to function as a pediatrician. Your job is going to be to recognize when development is off the trajectory in ways that are meaningful to affect social, emotional, and behavioral functioning. So with that said, pay attention now to the first year of life, because this gives us the early markers of engagement. So we're looking for things like communication, emotional regulation, and then later these domains are going to map onto autism, intellectual disability, sensory differences, and relational disorders. So let's take a look here now at the first column there, 0 to 3 months. So we look for early engagement here. We look for social smiling, orienting to faces and sounds. That means looking at them and going in there. To basic cooing. These are the foundational signs that the infant is tuning into the social world. If these are absent or very delayed, it's just a flag, not a diagnosis. but it's just a cue that you need to watch a little more closely. Now, between 4 and 7 months, babies begin to explore more intentionally. So they imitate sounds, they respond to your emotions, and they sit with increasing stability. So this tells us that their motor system and social reciprocity and sensory systems are organizing on schedule. So a child who does not imitate or who seems indifferent to the caregiver's emotional expressions may be showing early divergence in social processing. So by 8 to 12 months, then we're looking for communication to become richer. We're looking for tonal variation. We're looking for early proto words like mama, dada. We're looking for consistent responses to simple requests. Gesture imitation should also emerge here, clapping, waving, pointing. Gesture development is far more predictive of later language than early words, and its absence is one of the earliest observable signs for autism spectrum risk. So you're not memorizing milestones. You're learning to recognize when the early building blocks of social connection and communication and regulation are missing, so that, or they're unfolding in an atypical pattern in the early months to lay the groundwork for all later developmental pathways. Also, you need to grant grace up to 2 years for prematurity. They get extra ripening time up until 2 years old. So as we move now into toddlerhood and preschool years, development becomes much more observable and much more variable. So again, your task is not to memorize every milestone. It's to recognize when the core developmental domains are just off the trajectory in a way that matters for school and social and emotional and behavioral functioning. So between 18 months and 3 years, we expect steady motor growth, things like walking, running, pointing, climbing. But the real diagnostic gold here is that the communication and pretend play. So toddlers expand their vocabulary quickly. They start with simple phrases, then they imitate adults, and then they begin symbolic play. If a child is not pointing to share interest or is not engaging in pretend play by age 2, that's one of the highest yield early flags for autism spectrum. Now, by preschool age, 4 to 5 years, we're looking for more complex language and social behaviors, telling simple stories, using full sentences, cooperating in group play, and following multi-step commands. These milestones matter because they predict the school readiness. Now, a child who struggles with sequencing, cooperation, or reciprocal play may not meet the social or executive function demands of kindergarten classroom. So this is where learning disorders, ADHD, and autism start to differentiate more clearly. Or it could just frankly be not yet ready, underdeveloped, totally normal, just underdeveloped, late bloomer, if you will. And it's more common in boys. So the cultural context is essential because many of the behaviors we call milestones are actually culturally constructed. So independent sleeping, eye contact, and emotional expressiveness, these vary dramatically from families and cultures. So what looks like a delay in one cultural context may be completely typical in another. So this is why we always ask families, is this behavior of concern to you? Because their answer is going to help you distinguish true developmental risk from a cultural difference. So the purpose of this slide is not to catalog details as much as it's to teach you how to interpret early childhood development through a culturally informed, clinically relevant lens, and to pick up on red flags rather than to memorize checklists. So take a look at this slide now where I'm featuring the red flags. And the point of a red flag is not diagnosis as much as it's a prompt to dig deeper. So early infancy from 2 to 6 months. At this stage, we're looking for basic sensory and social engagement. A baby who does not respond to loud sounds, does not track faces, or shows reciprocal social smile, they could be signaling an early difference in their sensory processing or social orientation. So poor head control and floppy tone, those are also concerning. And that could suggest some sort of neuromotor issue rather than purely behavioral concerns. Late infancy, 9 to 12 months, this is a critical window for communication development. No babbling, especially producing the mama or dada sounds. This warrants an evaluation. So failure to respond to name is one of the earliest and most reliable early signs of autism risk. No pointing or showing objects suggests a delay in joint attention, which is foundational for social communication. So a baby who cannot sit unsupported at this age needs a developmental assessment for both motor and neurological reasons. So developmental pediatrics or developmental neurology is a subspecialty that can be of use here. When we take a look at toddler and preschool from 18 months to 5 years, here we're looking for more advanced language, gesture, symbolic play. No two-word phrases by age 2, that's a key red flag. Persistent poor eye contact, lack of imaginative play, absence of pointing are all significant early indicators of autism spectrum concerns. Regression, loss of previously acquired language or motor skills, this is one of the most concerning developmental signs, strongly associated with autism spectrum and Rett syndrome. Regression is never something to watch and wait. Always requires prompt evaluation if you notice the loss of previously acquired skills. By the time a child is in school, age 6 years to 21 years, red flags are often appearing as functional impairments rather than missed milestones. So you'll see things like poor impulse control, social isolation, chronic peer conflict, difficulty with self-care tasks, persistent motor coordination issues. Those things may signal things like ADHD, learning disorders, autism, anxiety, developmental coordination disorder. These children have passed early screens, but still seem to struggle because the demands of their daily life have outpaced their capacity. So if you remember nothing else from the milestone section, remember that these red flags are designed to prompt the investigation. They're not diagnosis. They're also not subtle. They're not ambiguous. These should always prompt you to do something. If it goes away at the next visit, fine. If it persists, you need to do something. Okay. So when we evaluate a child for autism, ADHD, learning disorders, or global developmental concerns, there's no single tool or observation that's going to give you the answer. Okay. Diagnosis in child psychiatry is fundamentally an act of triangulation. Between who? Well, you pull data from standardized tools, real world behavior, and the family system. So if you rely only on one of these, you're going to miss something. Now take a look at column 1 here. These are standardized tests. Okay. So the standardized tools give you objective anchors. So for autism, we use that MCHAT. And that's the modified checklist for autism in toddlers. This looks for joint attention and early social management in kids that are 16 to 30 months old, and it's a screening tool, not a diagnosis. So a positive MCHAT tells you to look closer, not label the child. For ADHD, the gold standard isn't what you see in your office, it's what the family and the teacher and the coach and the nanny tell you. That's why we use rating scales like the Vanderbilt or the Connors forms, because these come from more than one setting. ADHD is a diagnosis of pervasiveness across environments. Pervasiveness across environments, not a reaction to one specific classroom or parenting style. So, broad developmental screenings like the ASQ3 and the SWYC, all of these are designed to help catch global delays. These are things that are used to catch things like motor, language, and problem-solving issues, especially in younger children. This is what prevents us from mistaking a global developmental delay for ADHD or autism. Take a look at column 2 here. What you see here Standardized scores matter, but how a child behaves in front of you is equally important. So you want to watch their play. Do they share enjoyment? Do they invite you into their world? Do they play repetitively and alone? You're looking at transitions. How do they handle moving from the waiting room into your office? Does the sensory overload derail them? You're looking for transitions because they reveal more about executive functioning and regulation than a formal test will. That's also a time of stress, so you get to see what stress coping is. And times of transition could be parent leaving for work, time for bed, stopping play, that sort of thing. You always observe the parent-child dyad when you're looking at this. You're looking for where and whom do they seek comfort from. Does the parent scaffold the difficulties or rescue the child? Do they communicate warmth or tension? The dyad tells you volumes about the attachment pattern, stress, and the lived context of the symptoms. And then here we have column 3. This is where we integrate family context. We're going to take a 3-generation history on any child psych evaluation you're doing, adolescent and child psych, a 3-generation history. Not to hunt for a diagnosis, but what you're trying to do is understand the neurodivergent pattern that runs in families. You're looking to hear about quirky relatives, undiagnosed learning issues, mood disorders, because all of those are going to help you see the broader neurodevelopmental landscape. You're also going to screen for caregiver stress, because if the parent is burned out, interventions that require patience and consistency are likely to fail. So, not because the parent doesn't care, but they only have so much they can give. They're ultimately depleted. So knowing systems capacity shapes your treatment plan more than any checklist will. So then there's the environmental fit. Is this child whose temperament clashes with the school expectations? Is the family's cultural definition of success aligned with who the child is developmentally? Misfits will often masquerade as pathology. So accurate diagnosis requires you to synthesize the screening score, the observed behavior, and the systemic context. If you're missing any one of those 3 pillars, your formulation is going to be incomplete. All right, let's talk about what we're going to do and how we're going to diagnose. So let's ground ourselves now in the basic autism spectrum disorder as defined by DSM-5, because that's still how we're going to operate clinically. And it's expanded beyond the checklist because I want you to understand what these symptoms will look like in clinical practice. So autism spectrum disorder requires persistent deficits in social communication and interaction. This doesn't mean the child has no interest in people. It means that they struggle with reciprocity, using and interpreting nonverbal communication, understanding social cues, and managing peer relationships. These deficits must appear across multiple contexts, not just at home or just at school. The second domain is this restricted, repetitive pattern of behavior. The DSM requires at least 2 stereotyped movements like hand flapping or rocking, or a strong insistence on routines. It also can require highly focused or unusual interests, sensory hyper or hypo reactivity. So this is the same person that's too loud and they love to suck on lemons. It could be something like that. Sucking on lemons and being noise averse, though, is not in and of itself enough to make a diagnosis. So remember, these behaviors have to serve a regulatory purpose, not just simply be odd behavior. You might just like lemons as a toddler. So we also need to consider age of onset. So symptoms here have to emerge in early developmental stage, but they may not become obvious until social demands start to exceed capacity. So a bright, verbal young child may not be flagged until middle school when the social landscape becomes too complex to mask. Finally, there must be a functional impairment. A child can have autistic traits without having autism. The diagnosis depends on whether those traits significantly affect social, academic, or daily functioning. So that's why getting a diagnosis on the social media sites, you have a trait, you have a trait, you have a trait. Fine, we all have traits, we're all human. But traits do not equal diagnosis, similar as to when we talked about in personality. Now, take a look at the prevalence because it remains about 1 in 59, though this does vary by region due to screening practices. There's also a twin concordance rate of about 60%. So this emphasizes a strong heritability. There is also a male to female ratio of 4 to 1. So it's historically skewed. Girls are often underdiagnosed because they camouflage symptoms or present with internalized distress like anxiety. Boys just show you the anxiety. Etiologically, autism reflects both a genetic loading and an environmental modifier. So parental age, prenatal risk factors, early developmental exposures are correlates. They're not causatives, they're correlates. Autism is not caused by vaccines. That narrative has been debunked repeatedly and causes measurable harm by delaying proper diagnosis and treatment. The problem is, if you look at the age of when the vaccines are giving, that also happens to be the age when you're going to screen for autism. So basically, all you're doing is these things happened at the same time. They didn't necessarily cause each other. It's like saying ice cream sales go up as shark attacks also go up. The ice cream doesn't cause the shark attack. The shark attack and the ice cream are happening in the summer months when you're likely to be in the water and eating ice cream. That's the conundrum with correlation not equaling causation. Finally, this word spectrum is sometimes misunderstood. It does not mean mild to severe on a single line. Autism spectrum is a multidimensional formulation. So the child may have strong language skills, yet be profoundly impaired socially. Another may be sensory sensitive, but highly flexible socially. So the pattern is not the same. And so your job is going to be to recognize these nuanced profiles so that you can tailor your interventions and anticipate challenges and explain the diagnosis to family members so that they can, not burn out and have some support along the way. All right. So let's break down social communication deficits. What do these actually look like in autism? So the DSM gives us categories, but your clinical understanding is going to come from how these deficits will show up in real life. Social emotional reciprocity. This refers to the natural back and forth of emotional exchange. So autistic children may not share excitement spontaneously. They may not show you a toy, or they may struggle to respond when you share something with them. It's not disinterest. It's a difference in how their brain is processing social cues and internal motivation to connect. Nonverbal communication, our next item. Many autistic individuals have meaningful difficulty integrating gestures or facial expressions or eye gaze. So you might see a mismatched affect, for example, a child describing something sad with a flat expression or lack coordination of gestures like pointing and nodding and reaching and that sort of thing. The other one to take a look here is this relationship between developing and maintaining relationships. So autistic children may prefer parallel play, and they may struggle to adjust their behavior across contexts, or find any imaginative or cooperative play that might be very challenging for them. The key here is not a lack of desire for friends, but the difficulty in navigating those unwritten rules of social engagement. Now, on the right side of the screen here, we have contextual and cultural assessment. So masking and camouflaging. This is an extremely important nuance. Masking, many autistic youth, especially girls and high verbal individuals, will consciously or unconsciously learn social scripts to pass in neurotypical settings. They may ace your eye contact and your small talk and your structured tasks, but they're going to collapse with exhaustion afterwards. So masking can hide deficits during brief exams, and it's one reason girls often will go underdiagnosed. Social learning versus capacity. We also need to differentiate capacity from opportunity. So a child raised in a trauma environment may withdraw socially because it feels unsafe, not because of autism. A bilingual child may take longer to display certain social behaviors because they're processing a language load, not because they lack social understanding. So always ask, has this child had the opportunity to learn this skill? And then finally, the cultural lens can't be underestimated. So this is a critical factor to consider. Cultural norms shape what we perceive as impairment. So in some cultures, like certain indigenous and East Asian communities, children are taught not to make direct eye contact with adults. It's a sign of respect, not pathology. So if we apply Western norms blindly, we're going to overdiagnose. Remember, I told you on the first day of class, the DSM is Western American psychiatry, and we're going to apply that to the world. That's how we do it. It's not exactly the best way to do it, but that's where the money is. So the clinical pearl here is to compare the child not only to developmental norms, but to their cultural norms. Ask parents, is this behavior typical for children in your community? It protects against cultural bias in the diagnostic process. Okay. Restricted and repetitive behaviors, RRBs. These are one of the most misunderstood parts of autism. They're often viewed as strange and problematic, but clinically, RRBs tell us a tremendous amount about how the child regulates their nervous system. So the core manifestations are these stereotyped motor movements, sometimes called stimming behaviors. These are things like hand flapping and rocking and spinning and pacing. They're not random. These serve a purpose. They provide self-regulation. The child is managing anxiety and modulating their sensory input or expressing excitement. So stimming is not a behavior to extinguish unless it's unsafe. Now, I'll tell you, that's a controversial statement. The reason parents want to extinguish that is because it will often lead to social isolation. So that's something that's going to have to be decided. Life is trade-offs. Now, insistence on sameness. This is one of the hallmark symptoms of autism. Small changes like moving a toy or taking a different route or switching routines can create disproportionate distress. This rigid thinking is not oppositional behavior. It reflects how the autistic brain organizes predictability and reduces uncertainty. Another feature is this highly restricted interest. So intense or unusual interest like fans, maps, washing machines, dinosaurs, trains I hear are very popular, are not inherently pathological. They can become a bridge for learning and connection if you use them skillfully. So they only become clinically significant when they interfere with the functioning or become the child's sole area of focus. Another one is these core manifestation of sensory anomalies. So sensory hyper or hyporeactivity is extremely common. Some children are overwhelmed by sound and touch and textures, while others barely register pain or temperature. These sensory profile behaviors shape more often than you realize. So if we misinterpret them, you're going to misdiagnose them. Now take a look at the right side of the screen there for the soothing versus impairment. Now, this part's essential because the goal is not to eliminate RRBs, it's to understand whether the behavior is adaptive or maladaptive. Adaptive regulation, if the behavior soothes the child, organizes the attention, or brings joy and does not harm them, and harm is broadly defined because if it leads to ostracization, some will say it's harming, then your clinical stance is going to be accommodation. We don't want to pathologize harmless regulation. But maladaptive impairment, if the behavior causes harm like head banging or prevents the child from meeting basic needs, then you're going to have to intervene. And that may mean reducing sensory load or teaching alternative regulation strategies or modifying the environment and that sort of thing. With respect to treatment, the treatment goal is not to quote unquote normalize the child, it's to maximize their function. So we want to replace dangerous behaviors with safer ones, but you don't want to strip away a child's regulatory tools. So you need to remember the cost of masking. When children are forced to suppress harmless stims like quiet hands, they use enormous cognitive and emotional energy to appear socially acceptable. So that energy then is unavailable for learning and engagement or regulation. Now, there is a side of this that says they will build capacity and develop this endurance and get to a point where they can then function in a more typical manner. So masking will lead to exhaustion, but some will say that it will build some further capacity. So when you see repetitive behaviors, don't immediately ask, how do we stop this? What you want to do is ask, what purpose is this serving? And is there a safer way to meet that need? And that's both clinically effective and neurodiversity informed. So when you evaluate autism, you have to follow a systematic approach. Autism spectrum disorder is a clinical diagnosis, not just a single score, not a parent opinion, not a quick observation. This is a workflow that gives you a structure for doing it well and doing it safely. So universal screening is the first one. That's to identify risk. That's when you use something like the MCHAT RF, and that's administered between 18 and 24 months by the pediatrician, because those are the windows where early social communication differences become reliably observable. It's sensitive but not specific. So a positive screen tells you to look deeper, not here is your diagnosis. And you need to consider the developmental history. That's equally important to ask about regression. Did the child lose words or social responsiveness? You need to ask about early social behaviors. Did they smile, point, imitate? And make sure you review the developmental milestones. So even though you're doing psych, you still need to do a quick physical exam, right? You're looking for dysmorphology, skin findings, cafe au lait spots, abnormal head circumference. That can all point towards some sort of genetic or some sort of neurocutaneous condition that mimics or accompanies autism spectrum disorder. The other thing your goal is helpful to do is to rule out mimics. So your differential diagnosis is important. You can't diagnose autism until you've ruled out what? Hearing loss, so audiology is mandatory. A child who can't hear is not going to respond to their name and not develop language on time. That's not autism, that's a sensory barrier. You also need to consider genetic and metabolic factors. Fragile X, that's one of the more common ones. It's an inherited cause of intellectual disability and one of the strongest genetic mimics of autism. Lead toxicity, metabolic disorders, other medical causes can lead to autistic-like presentations. Extreme diets, like if the baby is suddenly on a low-fat vegan diet, that can cause major developmental delays, things like that. So you need to consider those. You also need to assess things like trauma attachment. A child raised in a neglectful and inconsistent caregiving environment is going to show poor eye contact and limited reciprocity, and they're going to have some very rigid behaviors. And that's not autism, that's them trying to survive. And, differentiating trauma from autism is one of the most important skills that you can develop. And then what you're going to do is you're going to build a profile of functional status. So once autism spectrum disorder is confirmed or strongly suspected, you build a functional profile. So this is where a multidisciplinary evaluation is essential. So you're going to look for speech and language evaluations to help you understand the expressive and receptive communication. You're going to involve occupational therapy to evaluate sensory processing and fine motor development. Cognitive testing will help you determine whether the intellectual disability is co-occurring, which can dramatically change your treatment planning for school supports and expectations for the developmental trajectory. And then you're going to return to the family system because you have to ask this question often. What are the demands placed on this child? And what is their capacity? And where are their mismatches? Because this is what's going to guide your interventions for more effective outcomes rather than just giving a labeled diagnosis and adios. So the sequence is simple but critical. First step is screen. Next step is rule out the mimics and then build the functional profile once you've made the diagnosis. So if you follow this structure, the goal is that you're going to avoid both overdiagnosis and underdiagnosis, and you'll generate treatment plans that can actually work. The last thing you want to do is demoralize a stressed out parent dealing with a developmentally delayed child. So when a child presents with social and communication delays, autism is only one of several possible explanations. So this slide lays out three common clinical mimics that every psych NP should be able to distinguish, and they are Rett syndrome, intellectual disability, and attachment or trauma-related disorders. So let's start with Rett syndrome. This is a rare genetic neurodevelopmental disorder, and this appears almost exclusively in girls and has a very distinct pattern. So the key hallmark in Rett is the regression after a period of normal development. So a parent will tell you she was talking or she was playing normally and then suddenly the skills were lost. You want to look for the stereotypic hand movements, specifically often wringing or washing motions of the hands in a rhythmic and continual pattern. You'll also notice a microencephaly and also some gait abnormalities that may emerge over time. The key differentiator here is that regression in Rett syndrome is global. It's not just social language. It involves regression in motor skills, hand function. It all deteriorates. And this is all driven by a known genetic mutation, MECP2 gene. You don't need to know that. Autism may still also co-occur, but Rett has its own trajectory and requires specialized medical attention. The other category is intellectual disability. So with intellectual disability, the challenge is global cognitive impairment, not selective social or communication deficits. So social engagement is usually appropriate to the child's developmental age. So a 10-year-old, say, with an intellectual disability may relate socially like a 4-year-old, but they do relate, and reciprocity is usually intact. The differentiator in intellectual disability is that the social skills will match the mental age. In autism, social deficits are below the mental age. So a child with intellectual disability may have some simple language, but will still attempt shared enjoyment and reciprocal connection. A child with autism spectrum disorder plus intellectual disability will show disproportionately impaired social reciprocity compared to their cognitive profile. Now, the attachment trauma distinction, attachment disruptions and early trauma create some of the most challenging diagnostic differentials because the trauma person may be the parent that's bringing them for care, and that's going to affect how this assessment may go. So these children may avoid eye contact. They may show social withdrawal. They may even display indiscriminate friendliness, meaning like they approach strangers with no hesitation. These behaviors can resemble autism, but the underlying mechanisms are different. So what you're seeing in this attachment trauma is this hypervigilance, which can mimic sensory issues. So a child who startles easily, avoids touch, or becomes overwhelmed in noisy environments may be responding to a threat, not a sensory processing difference. The key differentiator in the attachment trauma is that the children with trauma histories improve significantly when caregiving becomes stable, consistent, and nurturing. So their social functioning increases as their safety increases. So in autism, social communication deficits persist across environments, even with optimal caregiving. So when you evaluate a child with a social delay, the three categories, Rett, intellectual disability, and trauma, should always be on your radar somewhere because the patterns are distinct. And once you know what to look for, misdiagnosis in either direction can lead to ineffective or even harmful care. So let's shift into this Autism Spectrum 2025 research update here. So A major trend in the literature is this move away from binary categories like autistic versus not autistic and towards this dimensional model. So we have large-scale data sets that show that biological markers tend to track with symptom severity, not diagnostic labels. So in other words, the brain signatures associated with social communication differences or sensory processing challenges appear along a continuum, much like, say, blood pressure varies across individuals instead of being normal slash not normal. So it's important, not every autistic individual demonstrates a detectable biological difference. That's why we can't say the scan means you have it. Some show completely typical neural connectivity patterns, while others will show very distinct wiring profiles. So this is why autism presentations are so heterogeneous. The other thing to pay attention to are these genetic subtypes. So one of the biggest findings is that the identification of 4 genetic subtypes consistently associated with autism traits. So these clusters relate to different gene expression pathways, which may eventually guide personalized interventions, not pharmacologic treatment necessarily. So these are tailored supports based on the individual neurotype. Now, with respect to brain connectivity, neuroimaging continues to highlight altered connectivity in circuits that regulate attention and emotion processing. Specifically, we're seeing weaker connections between the thalamus and the potamen, which show up as a subset of autistic individuals. These are meant to be descriptive, not deterministic. This tells us some autistic brains may route information differently, not why someone is autistic. So another key update is this shared biological architecture between autism, ADHD, AUDHD, autism hyperactivity disorder, sometimes referred to as this AUHD, AUDHD. So this large-scale analysis shows overlapping brain-gene correlation patterns which align with what you see clinically. So you may see a high comorbidity and a symptom interweaving rather than clean, distinct categories. This supports that dimensional view that symptom clusters across diagnosis because the neural roots are often overlapping. So a critical takeaway is that these findings do not imply causation. They reflect how neurodivergent brains operate, not why they develop the way they do. The research supports precision-based support, that is to say, understanding an individual's unique neuronal profile rather than forcing categorical labels. So the long-term implication of this is going to be shifting from, say, fixing a disorder to identifying an individual's specific neural strengths and challenges, and then you tailor the support accordingly. And that's aligning more with the neurodiversity developmental pathway. Okay. So up until this point, we focused on diagnostic features and biological frameworks. Now we're going to pivot to something just as essential for practice. How autism functions within a family system and how cultural values shape what is perceived as impairment versus difference. So a neurodevelopmental diagnosis never exists in isolation. It interacts with parental expectations, sibling dynamics, school systems, cultural benefits about disability. And this slide highlights the domains that we have to assess to build interventions that actually work for the child in their real world environment. So this is a lot of where the work will be, that is in facilitating accommodation. So accommodation is not about lowering expectations. It's about creating predictability and reducing unnecessary cognitive load. So predictability. So visual schedules, transition warnings, consistent routines, all of that helps to reduce anxiety and support their executive functioning. Other accommodations include things like sensory support. So simple interventions like noise reduction, sensory breaks, weighted blankets, all of that can dramatically reduce someone's distress. Communication support, something like augmented and alternative communication devices. These were highly controversial when they first came out. Some people think they're still controversial. This is for clear, concrete language, and extra processing time are essential here. So this is not an optional add-on. So remember, accommodations, they're not therapeutic extras. They're supposed to be medically necessary for access to learning and emotional regulation. Now, there are some systemic impacts to consider here. The diagnosis affects the entire family ecosystem, not just the child. So sibling experience is something that needs to be considered. Because what happens is siblings become what they call glass children. They become transparent because the adult focuses on the autistic child, and then others become overly protective and resentful. What's interesting is you may then start to see the sibling develop factitious disorder because the only way to get any attention in this household is to have some sort of maladaptive problem. So you might see that develop as well. Parental stress, parents often are navigating through burnout and complex service systems and major financial strain because these are not cheap services. And they're dealing with a dysregulated parent can't consistently implement these interventions. So supports need to be targeted at them too. And then finally, the school partnerships. So a major stress point is advocating for the least restrictive environment. So Psych NPs can help families understand IEP language and collaborate with the school teams. When a family is overwhelmed, even the best clinical plan is going to fail. So you're constantly assessing for capacity before assigning interventions. And this cultural frame is going to shape how autism is perceived for more than, more than you can readily acknowledge. It's not commonly paid attention to. So there's a definition here of impairment. In some cultures, like I said earlier, avoiding eye contact is a sign of respect, not a social deficit. Some communities frame autism as a shameful defect, and others see neurodivergence as a normal variation. And that's going to affect who seeks help and who discloses and who's willing to engage. The goal is that interventions need to reflect the family values. Don't go trying to change the family values. You have to, you dance with the one that brought you. So if the family emphasizes academic achievement, your approach is going to differ, say, from a family who's prioritizing independence and social integration. And culturally misaligned care is really going to be abandoned quickly as you're going to have to ask families, what does success look like to you? And don't forget the concept of burnout for the caregiver and respite care, because it's not theoretical. It's one of the strongest predictors of family collapse is a child out of home placement. So you may find like divorce rates are much higher. Abuse and neglect can also tend to climb out of burnout. So building respite into the care plan is essential. Okay, let's do a case here. So let's walk through this case to reason through Leo. So Leo is a 5-year-old child with a very characteristic developmental pattern. So I want you to think like a diagnostician here, okay? Not just matching symptoms and labels and applying the framework. So Leo had a typical developmental trajectory until about 18 months old, and then something important happened. He suddenly plateaued and actually lost previously acquired words, about 5 to 10 of them. And anytime you see regression in the second year of life, autism must move to the top of your differentials, alongside conditions like Rett Syndrome and certain metabolic disorders. So he walked at 14 months old, which is within normal limits. Right now, Leo is limited pretend play and very intense. He has very circumscribed interests in train schedules, and he memorizes arrival times, but he doesn't use trains in imaginative or functional ways. Instead, he lines them up by color, and that type of pattern-based interaction is a classic tell for restricted repetitive play. And then he also shows sensory aversion, specifically to vacuum sounds, and there's rigidity around routines, and there's poor eye contact. So this profile is strongly associated with autism spectrum disorder clusters. Medically, audiology is normal, which is helpful because hearing loss can mimic social communication delays. There's no seizures, there's no dysmorphic features, nothing pointed towards a syndromic presentation. Sleep disturbance. He wakes up at 3 a.m. It's extremely common in autistic children due to a circadian rhythm difference. And then, so what are we going to do here? We need to reason through this. So given the regression at 18 to 24 months, the differentials need to include autism spectrum disorder, Rett syndrome, global developmental delay, or a trauma-related withdrawal. But Rett, in this case, can be deprioritized because Leo is a boy, less likely than that, and lacks the hallmark feature like the stereotypic hand-wringing, and trauma is less likely because the regression pattern predates school age and it's not in the context of specific anything. And the intellectual disability does remain part of the differentials, but his rote memory for schedules suggests an uneven skill development. So this is more characteristic of autism spectrum disorder. Now let's look at capacity versus demand. So Leo lines up trains to regulate himself. So that behavior is serving a function. It's not misbehavior. So if a school forces him to stop because it's not how kids play, we're going to artificially here increase the demands while decreasing his coping capacity. So the predictable outcome is going to be dysregulation and behavioral outbursts and burnout. So the goal is not to extinguish that coping behavior that's harmless. It's to expand the capacity over time while preserving regulation. And so the accommodation plan for someone like him would be for his sensory aversion to vacuum noise, think beyond avoidance. Think neurodiversity affirming accommodation could include things like noise canceling headphones during cleaning times, gradual exposure work paired with a co-regulatory behavior, or building predictability by announcing when the vacuum will turn on. Something like that. So what you're doing is you're protecting Leo's nervous system while helping him develop greater coping capacity. If we were talking about this in cognitive behavioral therapy terms, we would call this systematic desensitization. Now let's take a look here at Rett syndrome. This is one of the most important autism spectrum disorder mimics that you need to recognize. So Rett is rare, but the presentation is so distinct. So the root cause of this is that gene mutation. It's an X chromosome. The gene plays a key role in regulating neuronal and synaptic development. So when that gene, the MECP2, is disrupted, the neuron does not die, it malfunctions. And that's the distinction, because this is not classical neurodegeneration, but dysfunctional development. And Rett almost always exclusively affects females. Most male fetuses with this mutation do not survive to term. So a male child with regression is far more likely to be autism spectrum disorder or metabolic disorder or some other genetic issue, not Rett. Most cases are de novo. So that means that the mutation just appears spontaneously rather than it's something that's inherited. The developmental trajectory here is the biggest clinical giveaway. Children often appear to develop normally for the first 6 to 18 months, and then you see stagnation followed by a clear regression. A loss of acquired hand skills, reduced social engagement, and a slow head growth in some cases. The stereotypic hand movements, that's the hallmark feature, and it's the loss of purposeful hand use replaced by repetitive midline movements, ringing, washing, clapping, tapping. When you see this, Rett needs to rise to the top of your differentials. The other thing is neurological issues. Seizures are extremely common, so many children will display abnormal breathing patterns, hyperventilation, breath holding episodes, forced exhalation, sleep disturbance is also typical. These are all neurological red flags that help distinguish Rett from autism spectrum disorder. where seizures may occur, but they're not defined. And then motor impairment. So motor involvement is nearly universal. Early hypotonia, uh, progress to spasticity or rigidity later in childhood, and also some gait abnormalities like ataxia, apraxia. These are consistent and often progressive. So unlike classic autism, social withdrawal and Rett may improve as the child gets older, but the core issue here is the loss of the fine motor skills and the emergence of midline hand stereotypies, not a primary deficit in social reciprocity. So this is an important point to distinguish these two. All right. So now that's the biology. So let me just tell you a little more about Rett here. So stage one is an early onset, 6 to 18 months. In stage one, the development does not reverse yet. It just simply stalls. So parents may describe a slowdown in new milestone development, and you'll see some subtle signs that appear, like decreased eye contact, reduced interest in social interactions, and slower head growth velocity. Hypotonia, floppiness, that's often the first physical clue. This is a quiet stage and it's frequently missed unless someone is specifically tracking the development, which they should be. The pediatrician should be. Every couple of months you're in there. Stage two, this is the rapid regression phase. So this is the most dramatic and the phase that families find the most distressing. So children here will lose purposeful hand skills and spoken language. And this is also when the classic midline hand stereotypies, ringing, washing occur. And this is when the behavior becomes more challenging because there'll be more irritability, disturbed sleep, and prominent breathing irregularities. This stage often prompts the diagnostic workup because the loss is unmistakable. And then you progress to stage three. This is a pseudo-stationary phase. In stage three, regression slows and stabilizes, and some social engagement may even improve, which is an important distinction from autism. However, neurological complications will typically escalate in this phase. So seizures often begin in this stage, and sometimes they require complex medical management. Also, there'll be motor challenges here like ataxia and apraxia. That becomes more pronounced, especially for children who achieved early walking. By the time you get to stage four, this is late deterioration greater than age 10. Stage four is marked by motor decline. So many children will lose mobility and tone abnormalities and shift from hypotonia earlier in life to rigidity and spasticity. Scoliosis is also a major concern for these, and that often is severe enough to require orthopedic intervention, be it bracing or surgery. And communication abilities, interestingly, especially eye gaze based on interaction, will remain stable. So they can communicate, and eye gaze will remain stable. Cognition does not necessarily worsen. It's the physical limitations that progress in this grade stage four. So for families in stage two, the rapid regression is often emotionally a breaking point for them. They're going to witness their child lose abilities that they thought were stable, and they're going to have feelings of grief and guilt and fear for the future, and they're going to worry about the marriage and siblings, and the strain is quite common. So you're going to play a crucial role here for early referral for genetic counseling, coordinated medical care. Proactive psychosocial support can be helpful because there's going to be a lot of perceived trauma within the family here. So the differentials of Rett versus autism, both Rett and autism may present with social withdrawal and repetitive behaviors, which is why they're often confused early on. The distinction lies in the trajectory. Rett has a clear period of normal development followed by regression, followed by emergence of very characteristic hand-wringing stereotypies and motor deterioration. Idiopathic autism does not involve loss of purposeful hand use, nor does it produce the repetitive hand movements. And autism does not cause progressive motor impairment. So those are the differences that matter. What about Rett versus cerebral palsy? Well, it can mimic CP because both involve gait abnormalities, so tone abnormalities, motor dysfunction, but CP is static injury, typically due to a perinatal occurrence, and it does not progress. Rett is a progressive, or I should say regressive, neurodevelopmental disorder with sequential stages. So when the motor skills worsen over time and are accompanied by the breathing irregularities and the regression, the diagnosis of CP is less likely. What about Rett versus intellectual disability? Well, intellectual disability is often present within Rett, but intellectual disability alone cannot explain the full clinical picture. So what differentiates Rett is the neurological pattern, the disordered breathing, seizures, the microcephaly, and the distinct regression phases. So there is no cure for Rett. Management is entirely symptom driven and multidisciplinary. It'll include things like physical therapy, occupational therapy to prevent contractures, manage tone. You want to preserve ambulation as long as possible, but they often will lose that. Speech and communication, eye gaze systems become essential because purposeful hand use is lost, and communication access, meaning they can communicate with their eyes, can become a main clinical priority. The other problem becomes feeding challenges because aspiration risk is quite high in these children. So gastrostomy tubes are often required to maintain growth and reduce pulmonary risk of aspiration. Seizure meds, anti-epileptic drugs, dystonia agents, gabapentin, sleep aids like melatonin and trazodone are often used as well. The medication goal here is not curative, it's comfort and function and preventing secondary complications. Management in Rett is as much about the family as it is about the child. And the regression phase often triggers this profound grief response, and parents will feel as though they're losing a child that they once knew. So you're going to have to support the families through this process and offer respite care, and to help them contend with the physical demands of feeding, toileting, repositioning of a child that's 10 years old is going to be hard to do. All right. So the diagnostic criteria. So for intellectual disability, it's an important condition to differentiate from autism and one that frequently co-occurs in neurodevelopmental disorders. So the DSM-5 reframed intellectual disability away from purely an IQ-based diagnosis towards a functional one. So as Psych NPs, it becomes essential that you can anchor your assessment in adaptive functioning and not test scores alone. So the diagnostic criteria here is this, the evidence of deficits in intellectual functioning has to be confirmed through both clinical assessment and standardized testing. And we're looking at reasoning, problem solving, planning, judgment, and academic learning. So importantly, this is not about IQ alone. It's not a cutoff only. This is supposed to be a holistic assessment process. You're looking for adaptive functioning deficit. So this is the cornerstone of the diagnosis, and this refers to how well the individual meets developmental and sociocultural expectations for independence and social responsibility. So these deficits limit functioning in at least one area of daily life, be it conceptual, social, or practical skills. So this is what determines the severity, not the IQ score alone. And an individual with modestly low IQ but strong adaptive skills could function quite independently, while another with similar scores may require lifelong support. Now, the other thing to think about is the developmental onset. In order to qualify as an intellectual disability, these deficits have to emerge during the developmental period. So that is before age 18. So that helps distinguish intellectual disability from, say, cognitive decline due to an acquired brain injury or a neurodegenerative disease or some other adult onset condition. Epidemiologically, this intellectual disability, about 1 to 3% of the global population, making it more common than Rett syndrome, but less prevalent than autism spectrum. And the severity is categorized by the support needs, mild, moderate, and severe or profound, not by IQ brackets. So this reinforces that shift towards functional independence as the primary assessment target. Now let's look at these adaptive domains. So adaptive skills fall into three domains. Conceptual. So conceptual is academic functioning, reasoning, problem solving. Social domain is forming relationships, social judgment, and communication. And then the practical domain is personal care, daily living tasks, job skills. So assessment must consider all three of these to accurately determine the level of support that's required. So remember, severity is defined by support needs, not numbers on a test. Low IQ score doesn't automatically equal severe disability. What matters is how does the child navigate daily life, whether they can communicate their wants and needs, maintain safety, and manage their self-care. So when a child presents with a global developmental delay or an academic failure, our job is to sort out whether it reflects intellectual disability, that is a specific learning disorder, or something completely unrelated, like say a sensory deficit or an environmental deprivation. So this slide's going to walk you through that here. So this initial workup involves cognitive testing, right? And the starting point is always a formal cognitive assessment. Technically, an intellectual disability requires a full-scale IQ below 70. And keep in mind the standard error of measurement, which is usually plus or minus 5 points. So one score alone is never enough. So they will repeat this test at some point. The other thing you want to look at is adaptive functioning. So you want to measure that. So tools like the Vineland-3 or the ABAS-3 assesses how the child functions in three domains, the cognitive, social, and practical. So intellectual disability diagnosed only when both intellectual and adaptive deficits are present across real-world settings. There is some genetic and metabolic tests that can be done looking for things like Fragile X or looking for microdeletions or duplications, things like that. If the clinical picture raises the suspicion, that's what's going to raise the testing window expansion. The intellectual disability requires both intellectual and adaptive functioning deficits, not just poor school performance, because people will bring you in for school performance and expect a diagnosis to explain why their child is an underperformer. So you have to be careful with the label. Very sticky labels. So if adaptive functioning is intact, then the intellectual disability becomes unlikely. There are also specific learning disorders. So these are important to distinguish because they go undiagnosed for a long time and they can manifest in behavior problems, which buys you the wrong diagnosis. Specific learning disorders is a narrow academic deficit. It could be in reading, in writing, in math. It could be in all three to varying degrees. These children will often have average or above average reasoning abilities. They may even have quite high IQs, but they can't master one specific academic skill. But their adaptive functioning is normal. They can communicate, problem solve, care for themselves, and the barrier is just the academic skill itself. So, for example, someone with dyslexia, they may learn all the behaviors of reading and develop a fantastically audiographic memory to where they can just hear it and pretend to read. The tell is that they don't read anything on their own the first time, and they'll pick up voice inflection, where the page turn happens, and they won't even look at the book and they'll retell you the whole story as if they're reading, and you'll fall for it for a long time. Now we have talk to text, so it's easier to hide it more. Now those are adaptive mechanisms, but uh, it's hard to detect if the person's not expected to read and write. So reading aloud is actually a really good tell for that, and it's a good skill to practice, which is not done in schools much anymore. Um, Okay, let's take a look here at the sensory and environmental factors. So the third bucket includes things like things that mimic cognitive delay, but they're actually reversible. So vision and hearing impairment. So a child who can't see the worksheet or hear the language will appear delayed academically. Language disorders. So a child with an expressive or a receptive communication disorder may seem cognitively impaired when the core deficit is actually language processing, not reasoning. This is also can be like malformations in the mouth, like a tongue tie that never got released, so it sounds like a perpetual speech impediment, which means they're constantly hearing themselves wrong, and then people are relating down to them constantly, but it's just because the articulation's not there. Severe neglect or a lack of exposure to language can also be a factor. So books and structured learning can lack of exposure can suppress academic skill development and mimic intellectual disability. So if the environment or the sensory deficit is corrected, you should see the functioning improve. Now, you have to realize schools get extra pots of money for all of these special diagnostic labels, and it's really up to a good advocating parent and perhaps you as their ally to make sure that they're not mislabeled long term because they're going to rise to the level of expectation. If the expectations are chronically low, that kid is being set up for failure. So make sure that you are assessing thoroughly. That's why repeated assessments and targeted interventions matter more. So once you identify an intellectual disability, the work doesn't just stop with the diagnosis. Now the real work begins. This is going to be a lifelong condition, and your role is going to help them build capacity and reduce burden and try to align the support with their strengths. Adaptive functioning, is not innate. This is stuff that can be taught and scaffolded and reinforced over time. So it takes a while, but your job is to help the caregiver break tasks down into the manageable steps. And you want to promote these daily living skills. So direct instructions for hygiene, dressing, feeding, household skills, showering, like go in the shower, take off your clothes, get in the water, wet your body, rub soap all over the body, rinse the soap over I mean, some of this stuff is stuff you tell an adolescent sometimes, and they supposedly have average intelligence, but they seem to come out soaking wet and wondering why the clothes are sticking or there's a puddle on the floor. So sometimes you have to spell it out. You aim for balance, supervision that protects the child without removing all autonomy. Um, you know, you want to call that what's the phrase for that is called dignity of risk. That is, you allow exploration within safe boundaries that match their cognitive capacities. And family systems caring for a child with intellectual disability are going to face really long-term stressors. I have three families right now. The children are in their 30s, 40s, and 50s. They're intellectually disabled. Their parents are what? 60, 70, and 80. And succession planning is very difficult for this population because where are they going to live? Who's going to take care of them? What's the plan? And that's very hard to find resources for that. So parents may often feel trapped and burdened while they're trying to navigate this complex system. And the other thing is parents are often embarrassed by this, and this is a problem because what happens is they don't reach out for care and they don't get the support services. And then the kid turns 18 and they're no longer eligible because they never got the diagnosis at the right time. And so now they're really in a precarious situation. So that's something to consider as well. You want to encourage reaching out to access services. And then, of course, let's not forget the cultural context because that's strongly going to shape the expectations for independence and care roles and social value, even. The behavior interpreted as an impairment in one context may be accepted or even expected in another. So you have to contend with the social culture. And some cultures will emphasize interdependence rather than independence. So that really alters what the family is going to consider a problem and a goal worth pursuing. Disabilities may carry shame or spiritual interpretations in some communities, and that will limit the self-seeking behaviors. And also, you can't neglect the siblings. These are the floating elements that highlight crucial but often overlooked support. So the sibling support will prevent resentment and role overload. That sibling may end up becoming parentified as a result of this high demand other sibling. You want to look at community inclusion to combat things like isolation and build social skills for the child, for the parents, for the siblings. All of that should be considered. And then transition planning needs to begin early to avoid crises during the adulthood shift. So, unfortunately, that often gets neglected, and they're coming to you to put the eggs back in the shell, and sometimes there's not much you can do. Um, all right, why don't we do a little break here for about 10 minutes, and then we'll come back and continue on with the rest of this. All right, so this is specific learning disorders, and this affects about 5 to 15% of school-age children. And the DSM requires that symptoms have to persist for at least 6 months, even after targeted interventions. So this helps distinguish a true learning disorder from gaps caused by poor instruction or missed school days. And that's how you're going to distinguish, is this truly specific learning disorder. So what you're looking for is persistent difficulty. So the child struggles to learn or use a specific academic skill despite adequate teaching and support. And this persistence is the defining feature of specific learning disorder. So these difficulties do not simply resolve with more practice. So academic performance is substantially and measurably below what we'd expect for the child's age. And importantly, this mismatch must be documented using some sort of standardized testing and real-world performance, not just a teacher's impression alone. So also the test that they're standardized needs to be psychometrically valid. It's kind of like a real standardized test, not like a test the teacher developed in the class. So before diagnosing the specific language disorder, we have to first rule out some other explanations. Do they have intellectual disability, uncorrected hearing or vision problems, limited language exposure, trauma, psychosocial adversity? Because the goal is not to over-pathologize challenges that may have an environmental solution. Specific learning disorders are targeted and specific. So like a child with dyslexia may be gifted in conceptual reasoning. A child with dysgraphia could probably excel verbally. The difficulty lives in the skill, not in the global capacity of the kid. Reading impairment, say dyslexia, this involves difficulty with word reading and accuracy, and fluency and comprehension. So the underlying issue here is often a phonological processing deficit. That is difficulty mapping sounds to letters. They have trouble sounding it out. Written expression impairment, this is dysgraphia. Here you see a difficulty in spelling, organizing written thoughts, and using grammar and punctuation. These students will often speak far more coherently than they can write. And then there's mathematics impairment, dyscalculia. This includes struggles with number sense, number facts, calculation, or mathematical reasoning. And it's often overlooked because the symptoms can be misinterpreted as carelessness or anxiety. So these specific learning disorder subtypes frequently will overlap, and they can co-occur in high rates in people with ADHD and anxiety disorder. So when the frustration increases and behavioral symptoms often escalate, not because of oppositionality, but because the child cannot meet the demands placed on them. So now that we've covered what the specific learning disorders look like, let's take a look at the DSM-5 criteria to classify them. So criteria A is that the child must demonstrate a persistent difficulty learning or using an academic skill for at least 6 months, even after targeted intervention. Okay, because the goal is to rule out what? Poor teaching or poor instruction. And criteria B is this quantifiable deficit. The deficit needs to be measurable. The skills need to be substantially quantifiable below what's expected for the child's age. So this means standardized testing and curriculum-based measures and real-world performance all need to align to give you this coherent picture. If the child scores poorly on a test but performs adequately in class, the criteria are not met. So then criteria C, early onset, symptoms must begin during the school age years, although they may not become apparent or obvious until academic demands exceed the child's capacity. Now, when a reading shifts from, say, learning reading to learn, interestingly enough, depending on how old this person is, if this was not something that was diagnosable in childhood for whatever reason, it's not uncommon to have college-age students finally get diagnosed with dyslexia or one of these other disorders. So it just depends on where you are and the family you hail from. Some exclusionary criteria is criteria D. So finally, the difficulties must not be better explained by something else, like intellectual disability, uncorrected vision and hearing, psychosocial adversity, inadequate instruction, because of all of those things can mimic this condition. So that's what you want to rule that out for. Now, response to intervention. When you diagnose the specific learning disorder, the DSM-5 requires you to specify both the domain and the severity. So you would say something like reading, dyslexia, word accuracy, rate fluency, and comprehension, or written expression dysgraphia. And you would say in spelling, grammar, clarity, organization. Or you'd say mathematics, so number sense, calculation, or mathematical reasoning. And then also severity levels, mild, moderate, severe, and severity dictates the level of support that's needed. And where you can do that is through neuropsychological testing. Now, the intervention. So school systems often require evidence that the child did not respond to structured scientific instruction delivered in tiers. This is that RTI MTSS model. So clinically, RTI, response to instruction data, should inform the diagnosis, but it should not delay it when the symptoms are clear. So you want to avoid the wait to fail trap, which is popular in schools because it's very expensive to offer interventions for this. And so they create this wait to fail trap. So families are often told, just wait until the school year collects more RTI data, response to intervention. And that is risky because if the child has a clear dyslexia marker or a strong family history of learning disorders, then early assessment should proceed even if the RTI documentation is incomplete. Waiting allows the achievement gap to widen, and then remediating reading skills becomes exponentially harder after third grade. So really get this diagnosed. Now, let's take a walk through what actually happens once you suspect a specific learning disorder. This is the educational pathway. This is how you move from evaluation to intervention to ongoing support. So there are three major steps. There's the testing, the planning, and the partnership. Now, testing, this is a psychoed evaluation. So this is a comprehensive psychoeducational evaluation to help understand the child's cognitive profile. This is not just IQ testing, but you're looking for the relationship between capacity and actual achievement. So that's the gap that is often where the learning disorder becomes visible. You also assess processing, that is working memory, phonological processing, and processing speed. Now, these are the engines of learning. So when they're weak, the child can't access the curriculum even with the instruction. So you always want to rule out the sensory causes. That's why mandatory vision and hearing screenings will ensure that you're not attributing a cognitive difficulty to uncorrected sensory deficits. And then we get to the planning. So there's the IEP versus the 504 plan. So once evaluation is complete, the team will then determine whether the child needs an IEP or a 504 plan. An IEP provides specialized instruction. That would be things like the Orton-Gillingham-based reading intervention for dyslexia, which is remarkably effective, but remarkably expensive. And if they're in the school, because we have this right to education, the school's going to have to provide it. They are disincentivized to diagnose dyslexia. They'll say things like reading difficulty and the like, but really what they need to go back to, and I think the New York City School District has finally gone back to this, is phonemic awareness and teaching it this way across the board. So, or the Orton-Gillingham-based reading intervention for dyslexia, this is more than accommodations. This is targeted skill remediation. A 504 plan, by contrast, is about access. This does things like extended time and reduced distractions and preferential seating. These support the students, but they don't change how they are being taught and instructed. So the RTI data is brought in here as well. So schools need to document that standard instruction was not sufficient. And so that's the evidence base for guiding services that are going to be provided. Now, there needs to be a partnership between the family and the school. So none of this works unless the home and school are aligned, and oftentimes they're not. So that may be why you're not making progress, or the anxiety and the comorbid condition developing in the child. Homework load should match the child's capacity. So families need to be clear and communicate about the goals and progress. They need empowerment. So parents need to understand what their rights are under things like IDEA and FAPE so that they can advocate effectively without conflict. And monitoring needs to constantly be ongoing, and you need to set some measurable goals that are revisited at regular intervals. Not the twice a year that's standard done. You might need to separately reevaluate in between to ensure that the interventions are actually working and not further demoralizing the kid and the parents. Because you might think you're doing the right thing, but you've missed something here. So, as clinicians, you're not going to manage the IEP, but you're going to be the professional that the families will turn to when they're confused or overwhelmed or being dismissed by a school system. And so, you have to understand this pathway to make you an effective advocate for them as to how to navigate. So let's take a look at this case here. So look at Marcus. He's our 9-year-old fourth grader, and his teacher reports that he is consistently behind in reading fluency. And he gets his words based on the first letter, which is a classic move for inefficient decoding. But notice that he excels in science and can spend hours building complex Lego structures. So already we see an uneven skill development. There's weak reading, but there's strong problem solving. So, academic history, he shows persistent reading delays, but this is not a global learning issue. His strengths in science and engineering type tasks suggest intact cognition. So, what we often see in children with dyslexia or phonological based learning disorders is this higher level problem solving. So, what the teacher calls daydreaming happens primarily during the language arts and independent reading period. He becomes disruptive only when asked to read aloud because that's a common distraction technique because they don't want to be embarrassed. So, they will turn into the class clown in order to prevent that from happening. Um, Outside reading, he has no behavioral issues, and there's no issues at recess, and there's nothing wrong in his math and science skills, which is consistent with attention deficit hyperactivity disorder. So ADHD, where impairment needs to be present across at least two settings. So Marcus here is showing inattention only during reading tasks, but he's hyper-focused during Legos and science. And ADHD inattention does not selectively turn on and off by academic domain, although they can be hyper-focused on things that they really like. So the question is, does the pattern challenge the primary ADD diagnosis? In this case, they'd say it does because ADHD impairment has to cross the situational domains. And in a specific learning disorder, avoidance is domain specific. So Marcus's pattern strongly suggests a reading based learning disorder rather than a global attention problem. And so, what do we consider? This class clowning behavior during reading aloud, that could look like impulsivity, but kids are protecting themselves from shame. So, if reading is hard, turning it into a joke is a coping strategy. So, this ADHD impulsivity, or is it avoidance rooted in the embarrassment and anxiety about reading failure? So, in most cases, it's the latter. And the behavior here is not the disorder, it's the child's response to this academic vulnerability. So, to test this theory, what you're going to look for is the avoidance only during literacy tasks? Emotional response when reading challenges increase, and consistent focus during preferred non-reading tasks. So, all of that points away from ADHD and points towards a specific learning disorder. So what do you order? What do you do? How are you gonna help? Well, you need a psychoed evaluation, specifically targeting the phonological processing and decoding efficiency and this rapid automatic naming, right? Because these are the core deficits in dyslexia. So neuropsych testing can be proposed for that purpose. And continuous performance tests. So that also can be helpful for attention questions, but it can't diagnose alone. So always ask, when does the inattention show up? And if it's everywhere, think ADHD. But if it's task specific, then that should lead you towards a specific learning disorder. Now let's get to ADHD here. So ADHD is not diagnosed because a child is inattentive, impulsive, or restless. Those are symptoms that are non-specific. They are the fever of psychiatry. These are an indicator that something is wrong, but it's not the diagnosis in and of itself. So every time you see inattention, your first job is not to treat, it's to explain it. So you have to identify what else could be driving the behavior before you label it ADHD. And there are four major domains. It could be sleep deprivation in children. That often looks identical to ADHD, leading to poor focus, irritability, and impulsive behavior. So a 6-year-old sleeping 5 hours a night does not have the attention disorder. They have a sleep problem. It could be a medical condition. So iron deficiency, thyroid disorders, absence seizures, hearing and vision problems, any of those can show up as inattentive behaviors. So a diagnosis of ADHD without a basic evaluation medically is incomplete. The other thing that could mimic is trauma. So this radically reorganizes someone's attentionality. It could lead to hypervigilance, which looks like distractibility. It could lead to shutdowns, which looks like daydreaming. Or if a child is scanning the environment for safety, they can't simultaneously attend to like the multiplication table. And fourth, anxiety and mood. So anxious kids can't sustain attention because their cognitive load is spent on managing the threat, the perceived threat. So depressed kids will look distracted because they lack initiation energy. But neither condition improves with stimulants. And in fact, the anxiety can get worse with stimulants. So when you say ADHD is a diagnosis of exclusion, what we mean is this. You earn the diagnosis only after you have ruled out the conditions that are more common, more dangerous if missed, and more plausible for the child in front of you. So this is going to be the nature of an ADHD evaluation. So now that you've named ADHD as a diagnosis because you've ruled out those other things, this is going to give you an operational framework and the actual sequence that you can use when you evaluate someone with attentional concern. So the step one non-negotiable before ADHD is two things. One, you need to verify this chronic functional impairment, and you want to verify that the onset was before age 12. I know that's not the DSM-5 criteria, and we'll get to that in a minute. But suffice it to say, just for your own practical understanding, you want to qualify those two things. If those are not present, then ADHD is generally off the table at that point. There is adult ADHD. We'll talk about that. So column one here looks at emotional and behavioral rule-outs. So you want to start with the emotional and behavioral system. Depression can look like slowed processing or trouble initiating tasks, which is often mislabeled as inattention. Bipolar disorder might create brief periods of high energy that mimic hyperactivity, but again, we're not diagnosing bipolar in children. Anxiety and OCD can hijack the attention and intrusive worries or these ritualized thoughts. And trauma, especially chronic trauma, can produce hypervigilance that looks exactly like the distractibility one may equate with ADHD. So your exclusion test here is simple. Is the inattention episodic, mood congruent, or driven by fear? If yes to any of those, this is not ADHD. The next column here is this physiological and medical rule out. So you want to move into the physiologic medical domain. Sleep disorders like obstructive sleep apnea, chronic insomnia, these are some of the most common ones. So if you fix the sleep, does the ADHD disappear? And medical causes matter. Thyroid, anemia, lead exposure, seizure activity, all of that should be considered. And also, depending on age or incident, substance or medication side effects. Remember, step two was always rule out a substance-induced condition. So your key clinical question is, are there any somatic clues like snoring, fatigue, growth issues, or timing of patterns linked to medication that could explain the symptoms you're seeing? And then the third column here is this cognitive and learning rule out. So finally, assess the cognitive and learning domain. A child with a specific learning disorder is not inattentive everywhere. They're inattentive during the work that exposes the deficit, like reading or math, etc. That's not global ADHD. That's avoidance of an academically painful task. Likewise, if the child's attention matches their developmental age, for example, an intellectual disability, we're not dealing with ADHD, but we're dealing with a developmental expectation. So don't miss the sensory barriers, vision and hearing, auditory processing issues. All of those can look like attention problems on the surface. The exclusion probe is this. Is the inattention confined to specific academic demands? If yes, look for a learning disorder, not ADHD. So the algorithm is your guardrail. ADHD is never diagnosed based on symptoms alone. It is diagnosed only after these domains are systematically ruled out. And this is to protect children from being mislabeled and to direct the treatment to the true source of the impairment. Let's see what the question is here. Okay. Okay. So before we diagnose ADHD, we need to rule out the primary mood disorders, major depression and bipolar. Why? Because all three of these conditions share the same surface symptoms: inattention, irritability, and restlessness. So your job is to figure out what's driving all of them. So column 1 here, we have major depression. It's the core problem manifesting low energy and slowed processing, not distractibility. So the child isn't seeking stimulation here. They don't have the cognitive bandwidth to sustain engagement. So you'll see other features like anhedonia is another clue. So the child who suddenly loses interest in activities that they had previously loved is not exhibiting ADHD symptoms. And when the concentration tracks exactly with mood, when the brain fog comes and goes with depressive episodes, that's the depression, not the ADHD. So depressive symptoms are episodic. When the mood improves, then you'll see improved cognitive function. And ADHD never improves just because somebody feels better. Question.
Can you hear me?
Yep.
You mentioned, I know in the last slide you said not ADHD if the inattention is just specific to specific cognitive tasks like language or math. ADHD is inattentiveness across the board. But you mentioned previously that if the child is doing something they really love, let's say it's music or drawing or painting, then they might be able to focus really well. So, I mean, I guess, can you clarify, like, are there exceptions then with ADHD where
No,
a child can
ADHD,
actually focus?
yeah. So ADHD can have periods of hyper focus, but we're looking for across multiple domains. They can love one thing and still do things that they don't love well. Uh, what we're trying to distinguish in that last slide is how do you distinguish the specialized learning disorder from ADHD? And the main message there is that ADHD needs to be more pervasive, not just related to the one task. That's the
Mhm.
distinction. So it's distinguishing it from being only distractible due to the one academic thing that they don't like to do. Right.
Got it. But they can still have an exception with like let's say something they do love where they're
Sure.
able to hyper
Yeah,
focus,
yeah,
you said.
absolutely. Well, the thing they love is not going to be reading if they're dyslexic.
Right, but they could be ADHD and be able to hyper focus
Sure.
for
And yes, these two can
specific.
co-occur as well. That's the other problem here. You can have co-occurring
Right.
specific learning disorders and ADHD. Yeah.
Okay.
So the second thing I want to talk to you about is how the overlap can mimic with bipolar disorder. So bipolar disorder creates even more of a diagnostic confusion, especially because where you'll see this is that so traditionally we diagnose bipolar when in the late teens, early 20s. There was a movement for a while to diagnose pediatric bipolar disorder, and I always look at this askance because There's too much overlap here with oppositional defiance and just depression and anxiety and trauma. So I'm reluctant to diagnose bipolar disorder in children. It just doesn't fit the typical profile. But suffice it to say, there was a time where this was very much in vogue. And so there's a whole body of literature out there that talks about pediatric bipolar. Now, bipolar symptoms will cycle into distinct periods of mania, hypomania, depression. ADHD is not supposed to cycle. So, and grandiosity is another separating feature. So children with ADHD may be impulsive, but they don't have this grandiose superpowers thing about them. So bipolar, it exists, but this could be more applicable to, say, your 18 to 23-year-old who's getting a diagnosis for the first time, where you want to make sure you're not dealing with bipolar in lieu of ADHD. The reason you don't want to do this is you don't want to give someone with bipolar a stimulant because that is not going to be helpful and may indeed be harmful. So just keep that in mind. Now, in this third column here, we have clues that suggest what points us more towards ADHD. So what points you towards that path is, first, it's got to be a chronic, lifelong pattern that's present before the age of 12. And the mood disorders typically arrive later. So ADHD doesn't just suddenly show up in adolescence. And then second, this emotional lability in ADHD is reactive. That is, it's triggered by immediate frustrations or sensory overload. Someone with a mood disorder, they're going to have emotional shifts independent of triggers. Also, sleep, again, will help distinguish this. ADHD produces tired but wired children that have difficulty shutting down, not that dramatic need for reduced sleep that you'd see in mania or hypomania. So in ADHD, the inattention will persist even when the mood is stable. And boredom, not sadness, not hopelessness, is the primary trigger. They don't do well with boredom. So before you diagnose ADHD, you have to ask, is this a chronic and trait-like manifestation, or is this an episodic and mood-driven manifestation? That's the single question that will keep you from misdiagnosing, say, a mood disorder from ADHD. So anxiety disorders, when a child shows distractibility, restlessness, avoidance, clinicians will often jump straight to ADHD, but anxiety disorders and OCD can produce the exact same surface level symptoms. So your job is to figure out whether this is executive dysfunction or a worry-driven interference. So generalized anxiety disorder, these are children that are not distractible because of impulsivity. They're distractible because their internal world is loud. They're flooded with what if thoughts and perfectionism and future-oriented worry. They will have symptoms of somatic tension, which helps you identify this early. Like what? Stomach aches, headaches, tight shoulders, the classic generalized anxiety symptoms. And the clinical distinction to really note is in GAD, inattention gets worse when the child is under pressure and under stress. In ADHD, the opposite happens. High stimulation can often improve the focus. So always ask, does pressure sharpen the child or does it unravel them? And that's a good way to tell also. The other thing is to consider social anxiety disorder. So social anxiety is another major ADHD mimic. These children look inattentive in group settings, not because they can't focus, but because they're overwhelmed by scrutiny. So the quiet kid in the class who avoids speaking or freezes during group tasks often gets mislabeled as inattentive. The key differentiator is the situational specificity. So in social anxiety, functioning improves when the child is comfortable one-on-one or alone. In ADHD, the impairment is global, so it doesn't disappear when the audience goes away. And then in column 3 here, we have the obsessive compulsive disorder. This is the most commonly misdiagnosis in kids who look restless or distracted. So they could be ruminating with intrusive thoughts that's breaking their attention. They're not necessarily impulsive. Or they may have compulsions which interrupt task flow, so they're not disorganized. So pay close attention to the fidgeting. In OCD, fidgeting is purposeful. It's a ritual designed to reduce anxiety or prevent a feared outcome. In ADHD, the fidgeting is non-purposeful motor overflow. That's driven by hyperactivity. So kids with OCD will often appear rigid and perfectionistic or slow because they're internally negotiating the rituals and the rules and the need for symmetry and the like. So that's not executive failure. That's a compulsive loop that they're stuck in that can on the surface look like ADHD. So before labeling someone as inattentive, step back and ask, is the brain that is not able to regulate attention, or is this a brain that's consumed by fear? Because your ability to distinguish the two is going to be what prevents you from misdiagnosing the drives and prescribing appropriate treatment. Now, when a child presents with inattention or impulsivity, it's absolutely essential that you pause before calling it ADHD. Trauma, acute stress reactions, and attachment disturbances can imitate ADHD so convincingly that even experienced clinicians get misled if they don't follow some sort of structured process for diagnosis. So in column one, you have PTSD acute stress. These are children that aren't inattentive because they cannot filter information. They're inattentive because their nervous system is running a threat detection program 24/7. Their hypervigilance creates this constant scanning of the environment. So to a teacher, this can look exactly like distractibility. But underneath, it's a survival response, not a neurodevelopmental deficit. Avoidance is another diagnostic trap. So a child who shuts down during writing, reading, or transitions may be avoiding internal reminders of trauma. So that shutdown gets mislabeled as task refusal or oppositionality or not paying attention. And then what they're dealing with are these possible intrusive memories of flashbacks causing staring spells or zoning out that looks identical to like ADHD inattentive type. But the mechanism is entirely different. This is the internal reliving, not the executive dysfunction that's the issue. The differentiator is always the timeline. So in PTSD, inattention is yoked to triggers or reminders or some state of threat. It's not present across all settings and it's not lifelong. Whereas ADHD is not triggered by a trigger. Now, in this column two here, you have attachment disorders. So attachment-related pathology, you have reactive attachment disorder and disinhibited social engagement disorder. These will produce behaviors that look impulsive or oppositional or dysregulated on the surface. But the key is these children are responding to relational instability, not to core attention deficits. Oppositional behavior is often a protective strategy. It's an attempt to control the environment because safety has never been predictable for them. So what looks like impulsivity is actually a frantic bid for connection. See me, hold me, don't disappear, right? They're looking for superficial sociability. They're being overly friendly with strangers or they're violating boundaries, and that can be mistaken for ADHD impulsivity. But in attachment pathology, this stems from unmet relational needs and inconsistent caregiving, not from a hyperactive drive. So symptoms will change depending on the caregiver's presence, availability, and the level of felt safety. So if relational context shifts the behavior, you should immediately think of attachment, not ADHD. Now, complex trauma. This is chronic repeated adversity. And this creates a nervous system that lives in survival mode. So these children will show rapid mood shifts that resemble ADHD or even like a pediatric bipolar. It'll look like that. And the note of this is that the sleep is often disrupted. And when the sleep architecture is impaired, that daytime attention collapses. So it's not ADHD, it's physiology under chronic stress. The other thing is regression under pressure is another hallmark of this condition. So a child who loses learned skills during stress can appear as though they have executive dysfunction, when in reality, their cognitive resources are being hijacked by their survival needs. So always look for that ACE scale, that adverse childhood event scale, and a pervasive mistrust and a survival brain profile. If dysregulation improves with safety and co-regulation, then you're not dealing with ADHD there. So the bottom line in all this is ADHD, the attention system itself is impaired. In trauma, PTSD, attachment disorders, the attention system is functioning, but it's being overridden by fear and mistrust and a survival response. So if you don't rule that out first, you're going to cause a misdiagnosis and then possibly put this child on a stimulant and make the situation worse, because stimulants are the first line treatment for ADHD. Okay, what about sleep issues? Well, before we diagnose ADHD, of course, you need to rule out sleep trouble, right? Medical conditions that directly impair attention and impulse control and behavior. So if you don't do this step, you will misdiagnose, full stop. So remember that inattention, irritability, hyperactivity, they are the final common pathway, but sleep disorders, anemia, thyroid dysfunction, lead exposure, and absence seizures can all produce those same symptoms. So let's look at sleep disorders here. So sleep disorders, because if you skip this, everything else falls apart. So sleep deprivation can mimic ADHD so perfectly that stimulant treatment may appear to work, but only because you're temporarily overcoming the sleep-based cognitive fatigue. It's like giving them a cup of coffee, essentially. Obstructive sleep apnea is one of the biggest culprits in children. So you want to ask about things like snoring, mouth breathing, and enlarged tonsils. If the pediatrician can't tell you this, the dentist might be able to. And the child who stops breathing 20 times per hour will absolutely look hyperactive and inattentive the next day. So insomnia and circadian rhythm issues can also erode that daytime functioning. So a child who's falling asleep at midnight and waking up at 6 and has a neurocognitive profile on testing that looks identical to ADHD. The qualm is if you fix the sleep, the ADHD symptoms will dramatically improve. So you can use like the Bears sleep screen or refer to polysomnography, and they do it for kids too. The other thing to look at is the second column, this thyroid anemia. So iron deficiency anemia is a quiet saboteur. So low ferritin levels lead to fatigue and poor sustained focus and restless legs, and that will then disrupt sleep. So child with a ferritin below 50 is often presenting as someone with ADHD. And thyroid dysfunction is another attention disruptor. So hypothyroid looks like a sluggish, foggy, inattentive kid. Hyperthyroid kids can look anxious and activated and impulsive. So either one can be mislabeled as ADHD if you don't check labs. And then also vitamin D and B12 deficiencies can affect cognition. So they can affect processing speed as well. So what do? Easy enough. Check a ferritin, CBC, TSH, free T4, vitamin levels, correct any deficiencies, and see if the behavior symptoms resolve, or work with pediatrics to have them do that. And then also, and you can order that, by the way, because your certification will be in family psychiatry. So you can actually order that and they can go to the lab and have that drawn, but most will go to pediatricians to have that drawn. The other thing is lead and neuro. So let's talk about neurologic mimics. So lead toxicity causes cognitive decline and irritability and impulsivity and aggression. And so these are classic ADHD symptoms, but the underlying cause is environmental poisoning, not a neurodevelopmental disorder. So lead level is easy enough to check that as well, as will an EEG be. Okay. So now that we've ruled out mood disorders and trauma and sleep, let's get to actually diagnosing ADHD. So there are two symptom clusters. You have inattention and hyperactivity and impulsivity. So the diagnosis requires 6 or more symptoms in either domain. Not occasionally, but consistently, and it has to be developmentally inappropriate. So, inattention is the classic picture. You get careless mistakes and difficulty sustaining focus and not listening and disorganized and losing things. And some of that is age appropriate, but some of it is not. And so, these children are not choosing to ignore you. Their executive system just can't hold that thread consistently. Whereas the hyperactivity, impulsivity, this is that motoric and somatic picture. They're squirming, they're leaving their seats, they're climbing, there's excessive talking. That's that blurting out answers and interrupting. It's not naughtiness. This is just speed without brakes. So the duration matters because symptoms have to be present for at least 6 months and they must exceed what's normal for the developmental age. The other thing to pay attention to is the developmental onset. So symptoms have to begin before age 12. So if a teenager suddenly becomes inattentive for the first time, think depression, trauma, sleep, substance, etc., or drug seeking for performance enhancement to do better on a test. The other thing to look at is setting requirements. So symptoms must be present in two or more settings, home, school, and social. And if the attention only appears in math class, that's not ADHD, that's a content specific struggle. So think of a specific learning disorder there. And what you're looking for is a level of impairment. The symptoms have to meaningfully disrupt the child's academic, social, or daily functioning. Otherwise, you're just diagnosing traits, and traits is not a diagnosis. So if a child has intense trouble focusing in stressful environments, but focuses beautifully when calm and supported, that's not ADHD. That's context dependent executive functioning. Look for something else. So this is the theory of the biology for ADHD. They think this is fundamentally a disorder of the fronto-subcortical pathways and networks, and the neurotransmitters involved in this are norepinephrine and dopamine dysregulation. So you'll notice that's where a lot of the medications tend to aim themselves. There is a theory about hyperconnectivity and stronger coupling that ADHD often will show and attention emotion network coupling. So that contrasts it with autism spectrum disorder, which typically shows a weaker or underconnected pattern. But there is no single gene that's driving this per se. It can occur in families. The question is it a learned behavior or a biological determinant? Depends on your school of thought. Let's take a look at this restless perfectionist we have here. We have this 12-year-old Mia. And the teacher notices that she's constantly rechecking instructions and worries her peers are judging her, and her grades are slipping, but not from impulsivity or poor planning. She's burning cognitive bandwidth here on anxiety. And at home, she's exhausted after school. She's irritable, complains of stomach aches, and spends hours erasing and rewriting her homework to make it perfect. So this is not ADHD. This is some sort of obsessive compulsive situation here. And so the testing is going to give you the clues. So what clues confirm the anxiety? Well, ADHD kids forget instructions. Mia rechecks them repeatedly because she's afraid she's getting them wrong. So her inattention shows up only in these performance situations. And her perfectionism is a high cost coping strategy. She gets work done. She just pays for it with exhaustion and insomnia and the like. So the accommodation strategy here to help her is not focus tools. She doesn't lack focus. She lacks psychological safety. So this is the person you want to give permission to make mistakes and not do a perfect paper. Maybe allow for pass fail or reduce the volume of problems or create evaluation free practice spaces. Um, that's going to be the trick there. You know, draw a straight line on the paper and see how long it takes them to fall apart. And then you have kind of a tell there. So there is an overlapping here between ADHD and the autism spectrum. It isn't rare. What's rare is recognizing the overlap. So features of one condition can mask or amplify the other, leading to misdiagnosis. So this is a double hit on executive function. The ADHD is driving the difficulty with initiation and sustaining effort, and then the autism is bringing difficulty with flexibility and task switching. So the brain gets stuck and overwhelmed at the same time. And so you'll get a divergent sensory profile here. The ADHD brain is seeking stimulation while the autistic brain is avoiding overstimulation. So what happens is you'll see this sensory seeking followed by sensory overload, like hitting the gas and brake pedal at the same time. And then the individuals use autistic rigidity to contain that ADD chaos. And then the ADD social drive to hide that autistic fatigue. And at the end of the day, you get this burnt out kid. So what you're trying to do is guard against this overshadowing. Um, and you also don't want to over pathologize. So ADHD hyperactivity will hide this autistic social withdrawal, and the autistic routines can be misread as ADHD coping behavior. So you can't treat one without recognizing the other. And so your job is to recognize the interplay and provide some explanatory clarity so that, you know, the parents don't think I'm imagining what am I seeing here. So what happens is after you diagnose this autism with ADHD and the full criteria for both ASD and ADHD are independently met, and you notice the social difficulty has to come from the autistic social cognition portion, not the ADHD impulsivity. The inattention is going to come from the executive dysfunction, not the autistic internal preoccupation. Both conditions are present. You're going to need a distinct stream of interventions for these people. So stimulants or non-stimulants for focus, social coaching or pragmatic supports for the autism spectrum. One diagnosis is not accounting for all of these impairments. Um, so a child labeled with socially awkward due to the ADHD impulsivity, interrupting and talking, and that's not because of autistic social processing, that's the ADHD feature. Whereas a child who's got this sensory sensitivity but no autistic rigidity, that's the communication deficit there. So what do you do with this situation? Well, it's not about the right diagnostic code. What you're trying to do is treat the functional need, which symptom is most bothersome, and what scaffolding can be put into place, what sort of sensory accommodations, coaching, etc. It's not a one and. You have to see which one is causing the most deficit, and that may change as time develops as well. So there are these shared patterns, and clinically, this shifts the goal. The goal is moving from normalization to functional capacity. And your aim is not to make the patient behave like a neurotypical student, but to build those executive supports over time to reduce the burden of constant compensating. So you treat the neurotype, not the contradictions. You support the function first, and then you change that long-term trajectory as you proceed. In other words, don't just think ADD stimulant, that's my job. Don't just think autism antipsychotic, that's my job. Don't do that. What you want to do is figure out what's causing the most deficit and go after that. What will maximize the most function? So what you're trying to do is de-emphasize the pharmacology because medication has its role, but it's a support tool. It's not the mainstay. And your real job is matching the child's current neurocognitive capacity to the demands you place on them. So kids don't burn out because they're weak. They burn out because the gap between capacity and expectation. So the way you do this is you pick the functional priorities. We're settling for good enough. We're not chasing perfect behavior. We're chasing meaningful participation in learning, and that requires some accommodations. And we're trying to make you as independent as possible. And we're targeting sleep hygiene and feeding. And we're trying to build some sort of relationships. So autonomy, can the child say no? Can they ask for help? Can they make choices about their body and their time? You're trying to encourage as much independence and autonomy that's age appropriate. So let's look at this capacity resilience demand. So the left side is the survival cycle. On the left, you have this child running on emergency mode physiology, masking meltdowns, withdrawal, and shutdowns, not because they're oppositional, but because the system is overloaded. And so when the demand stays too high, the child is borrowing energy from tomorrow to survive today, essentially. And so when you're surviving, you can't learn, and you get this chronic dysregulation, which blocks your skill acquisition. And this is how the bright, motivated kid ends up getting stuck. And then what you have is this transition moment. So the intervention here is not try harder. The intervention is rebalance the system. So you match the demand to the child's current capacity and then slowly build the capacity from there. Whereas if they're in the thriving cycle, we modify the demands to build skills together so that capacity expands. So the child suddenly has energy for growth and they can get through the day. And this is where resilience lives. They're not white knuckling anymore. the task becomes manageable. So you can't treat behaviors in isolation, and you have to treat the demand by increasing capacity sometimes. So what can we do to build capacity? Well, this is the first lever. Most people jump to skills, executive functioning, social learning, but this is the critical point. Capacity building only works when the child is regulated enough to learn. And then to go to reduce demands, sometimes the most therapeutic thing we do is to simply make the environment quieter for the child's brain. And then we slowly build up the stress response that way. And then to teach resilience, this is the third lever. You don't want to just push through and grit for everything. You want to teach them cooling down strategies and teach them to advocate for their needs. And then they will learn to tolerate smaller amounts of increasing discomfort over time without tipping over into shutdown. Because ultimately, we're going to have to build distress tolerance, uh, and resilience and capacity are just a part of that. So that's how we're going to shift them. So whenever we talk about neurodiversity, this issue of accommodation, that's the removing barriers. This is the helicopter slash lawnmower parent. The problem with that is it can enable this learned helplessness. So that is useful at a time, but over time we need to stop. We need to allow for, I'm sorry, that's the enabling rather. We have to allow for accommodation so they can build capacity, develop their scaffolding and grow. We don't want to put them in the typecast of constant enabling where we remove all stress from their life forever and pave the road and they never really learn how to grow into full functioning adults. So the golden rule here for decision making is, does this support help the child grow or avoid the task? If it helps them to do the task, it's accommodation. If it protects them from the task, then that's enabling. So the goal is not to rescue kids from difficulty because life does not get easier. Life only gets harder. What you're trying to get them to learn to do is to get good at doing hard things. So you don't want to remove you want to remove the unnecessary barriers so they can meet the right amount of difficulty. And so this involves some family system interventions. Parents are going to carry the heaviest load here because, it's a lot of unmet, unrealized expectations. They may have some guilt, but this will get better as the child develops more capacity along the way. And they need individual time with the parent where they're not in the shadow of the identified patient with respect to the siblings because they're going to need to be attended to as well. They need to be included in this family dynamic. Um, and then also the couples need to work on their relationship because any tension and strife there will be perceived by the child and can be seen as a threat to attachment and stability. So that's going to be a major factor as well. Um, and then providing options for respite care to help stabilize a family in crisis. Of course, the cultural trend needs to be considered here. We mentioned this previously with respect to things like eye contact and independence timelines. Remember, our bias is this Western neurotypical explanation. That's our bias. So at least be aware of it and consider the audience that you're working with. Um, and be careful of the language because words like disorder and the like may be off-putting, but you have to find the language that's going to work, that's going to lead to you communicating effectively because your job is not to force a neurotypical mask or cure an underlying neurology because that's not possible. You're going to just try and reduce suffering and maximize their ability to function in a culturally aligned way. So this is Mia, 10-year-old fourth grader, history of dyslexia, escalating after school meltdowns and sleep rhythm that's completely inverted. And the key here is to resist jumping to a single label explanation and try to map the interaction of multiple overlapping systems here. So I'm just going to go to the end because we're coming short on our time here. But essentially, if you look at the right side here, you have what is the primary driver? It's the dyslexia with the fatigue and the anxiety related to academic stress. So we have undiagnosed ADHD with a hyper-focus masking deficits, as well as autism spectrum disorder profile given this encyclopedic interest. So, or is the root of the problem simply sleep deprivation impairing executive capacity, right? And so you have this capacity demand map. She has low capacity for early sleep onset, sustained attention, reading at the grade level, sitting still, etc. So first line accommodations would be to, reduce some of the demands, switch to audiobooks for homework, provide some scaffolded reading tasks, and adjust the expectations around bedtime. Then we establish some gentle melatonin, some sleep hygiene. What you're doing is you're trying to gradually see how much of the behavior you can regulate behaviorally. And the goal is not to fix the dyslexia, but to get the brain to work with it, because you can't fix it. So when you stop chasing the label and start mapping the capacity versus demand, the case gets clearer. She's not oppositional. She's not unmotivated. She's not inattentive. She's overloaded and exhausted and undersupported. So that's the problem here. But you can see, go through this, you can see how she can buy herself a bunch of unnecessary diagnoses. So where variation becomes a disorder. So we're asking one of the hardest questions here. When does it cross over? So the medical lens says it's about access and safety. So this unlocks services. So that's why we use the medical lens, right? It's basically a label that's being used as a tool to get you to the care you need to function at your highest level. The right side is this neurodiversity lens, and that is identity and adaptation. So the goal of that is to reduce stigma by framing the differences as just neutral variations. This is just me, but it also prioritizes their own autonomy and goals and their own definitions of success. So we're doing a both and approach here. So the clinical boundary line is a variation becomes a disorder only when there's a significant functional impairment or there's significant personal distress. So that can't be resolved by simple environmental accommodations. So if accommodation resolves the issue, then we don't have to put a disorder label on it. But if impairment persists even with support, then the disorder diagnosis tends to fit more so there. All right, what are the key takeaways here? So ADHD is a diagnosis of exclusion. We don't start with it. We do the rule outs. We look for other conditions that are reversible: mood, anxiety, sensory, medical capacity. Demand resilience model, the symptoms improve when the mismatches decrease. So either we raise the child's capacity or we right size the demands. And if you ignore the mismatch, then you lead to frustration and burnout. You want to accommodate, not enable the child, and you're going to support the parents in doing this. The distinction is the determining factor for long-term independence. Does this support them and help them do the task, or are we helping them avoid the task? And then also, of course, treating the system that's involved. Um, that includes the family, the siblings, and the cultural context. And these are reliable evidence-based resources, but you have to kind of use them in the manner that's most useful for them there. And so the goal of treatment really is not to cure the neurodivergence, but to ensure that the child's environment and skills are aligned to allow them to thrive. So that is the end of this. I will stop the recording here.